Second white coat. Subscribe and like. Let's learn medicine together.
A patient is rushed in, unresponsive, and their kidneys are failing. You have minutes to make the right call. To diagnose acute kidney injury, you have to sort the problem into one of three physiological categories. Think of the kidney as a plumbing system, shown in this diagram. The issue is either pre-renal, meaning a kink in the supply line, intrinsic, meaning a damaged filter, or post-renal, meaning a blocked drain. Our case gives us a 44-year-old man found unconscious. To isolate the cause, we must map every detail of this clinical presentation to its corresponding anatomical site of injury. Look at the initial vitals. He is hypothermic at 35.6 degrees Celsius and responsive only to pain. In a middle-aged adult, this presentation points straight to toxic ingestion or central nervous system depression. Your differential immediately includes toxic alcohols, opioids, and sedatives. On physical exam, you note dry mucous membranes. This finding points towards systemic dehydration, suggesting we might be dealing with a pre-renal issue, that kinked supply line we talked about earlier. You start treatment with IV fluids. His mental status slowly improves, which makes sense if he was severely dehydrated. But then, urine output decreases and he develops flank pain. Why is this sudden lack of expected improvement the most important sentence in the question? Because the patient isn't responding as expected to hydration. The pathology has shifted from a simple volume deficit to established intrinsic damage within the kidney itself. To confirm this, we look at the objective evidence inside the kidney. The renal biopsy shows marked ballooning and vacuolar degeneration of the proximal tubules. Those specific descriptive pathology buzzwords translate directly to a functional diagnosis: acute tubular necrosis, or ATN. Looking deeper into the tubular lumen, we find multiple oxalate crystals, the hallmark evidence of the underlying toxin. The parent toxin, ethylene glycol, metabolizes into oxalic acid. This acid binds with calcium to form these specific tissue-damaging calcium oxalate crystals. Finding these specific microscopic crystals provides the definitive link tying the intrinsic tubular damage directly to an exogenous toxic alcohol ingestion. Let's rule out the other options. Filtered monoclonal light chains point to multiple myeloma. That typically presents in an older patient with Crab findings, and the biopsy would show eosinophilic casts, not oxalate crystals. Increased endogenous parathyroid hormone causes calcium stones. However, those stones create macro-obstructions in the ureter. They do not cause diffuse, microscopic proximal tubular ATN. Microthrombosis suggests HUS or TTP. Our patient lacks systemic signs like schistocytes or hemolysis, and microthrombosis primarily injures the glomerulus, not the proximal tubules. These alternatives confuse macro-obstructions with microscopic crystals, or glomerular damage with tubular injury. The abnormal biopsy proves the problem is no longer pre-renal. The site of injury is fixed within the tubules. This flowchart tracks the chronological disease progression. An exogenous toxin, specifically ethylene glycol, breaks down into toxic metabolites. Those form oxalate crystals, which cause proximal tubular injury, leading to ATN and ultimately acute kidney injury. If you see altered mental status paired with oxalate crystals, you are looking at ethylene glycol. If you see ballooning and vacuolar degeneration of the proximal tubules, you are looking at ATN. Reaching the correct diagnosis means moving past isolated findings and seeing the complete physiological chain reaction